Hey, gang, and welcome to another episode of Try Not to Curse. Ooh, I started the music over again. Mike, this is the problem. Every time he expects me to be good with the button, I'm terrible with the button. Not a professional gig here, guys. We are here today with my friend Kateland. Kelly, we know each other. I think you're 2 years younger than me. You graduated in 2004?
Yep, 2004.
Okay. Yeah. So you and I have known each other throughout school. Your mother worked with my dad briefly for a time, so I'm very familiar with your whole family. Just love your mom. Hi. Hi, Heidi. But you have gone through something, and I would imagine still are going through something. You were diagnosed with MALS, but much like many of the guests on this show, you had been misdiagnosed for years prior to that. You now have a book that has just released, The Secular Prayers of Medicine. So we're going to get into all of these wonderful things. But first I want to start with, so again, the last time we saw each other in person, face to face, was high school. You are in the medical field now, but was that your interest when you were in high school? Did you always want to be in the medical field? Was that what you're looking to do when you went off to college?
So yes and no.
Okay.
So my journey into medicine was actually motivated by self-preservation more than anything. So I write in my book, in my introduction, that I always wanted to know why my body was pixelated with pain. I don't know what it's like to not have pain. So when I was a kiddo, I was misdiagnosed multiple times, to the point where I questioned the diagnosis as a 16, 17, 18-year-old and saying, with my limited resources, this was before WebMD,
right?
No Wikipedia. I said, it doesn't make sense what you're doing. And I was told by more than one doctor, quote, "You're not the doctor. I get to make the decisions." And I decided to do something about it.
That's
my mom is a stained glass artist. My dad's a carpenter. I'm the first one to go to college, so I couldn't afford to become a doctor. So I became a physician assistant, though now we're called physician associates.
okay.
Yeah, a new title change, relatively new.
Okay. Well, so let's start with your initial symptoms. So like you said, you've been in pain in one form or another your entire life, which I can't imagine what that's like. But what were kind of the initial signs that something was going on, that something was wrong?
So when I was born, I had a ventricular septal defect, which is a hole in the bottom half of the heart. More than that, though, I wouldn't take any formula or breast milk. So my mother has journals going all the way back to 1986 when I was born. Tried 1 ounce of formula, vomited immediately. Half an ounce of formula, vomited immediately. My mom went to many pediatricians saying, "What's going on here?" It might be cerebral palsy. It might be colic. She got everything from in between. At one point, they even actually tested me for HIV because it was 1986. And they said, well, we don't know what's causing your daughter's abdominal spasms, failure to thrive. Ultimately, it kind of went away mysteriously at some point when I was a young child. And I enjoyed quite a few years of early childhood of being healthy. But then as a teenager, I got sick again. So we live in Connecticut, and it first manifested as joint pain. So easy diagnosis, Lyme disease. All right, well, the Lyme tests were negative. So they called it seronegative Lyme disease. Also not quite correct. It got to the point where I couldn't move my hand in the mornings. I remember my mom and my dad helping me get out of bed, and my hands would be cracking at 16 years old. So that caused a lot of tests. I ended up going to Hartford Children's Hospital, where I went through several liver biopsies because my liver enzymes were through the roof. And tick-borne illness didn't necessarily explain that. So the liver biopsy was ultimately diagnosed as autoimmune hepatitis, which is when your body doesn't recognize part of your body and starts attacking it. So autoimmune, your immune system was working against yourself. It's a diagnosis of exclusion. Treatment was very high dose steroids and then oral medication that's an immunosuppressant. But it's very similar to oral chemotherapy, very, very similar side effect profile. And so I started that at about age 16 and was in that treatment regimen for almost 8 years or so. At which point I decided I'm going to write a really killer essay to get into some kind of medical school. And I got into undergraduate. I did a PA program with a concentration in creative writing and journalism. Because of issues with my health and dosage changes, I ultimately could not maintain that GPA in that undergraduate program. To say I was devastated is an understatement.
Sure.
Because I had spent all this time saying I could do this, but my body just wasn't cooperating. So I moved back home, took a job with Boehringer Ingelheim in kind of sad shame, but also a lot of gratitude because they do good work. And I got a call from a PA program that said, hey, you were on the wait list. We start in 2 weeks. The spot is yours if you want it.
Oh, great.
So I moved almost sight unseen down to Virginia to start that journey.
Wow. That's
how I got into medicine, the short of it.
Yeah, but that's amazing. I mean, I give you so much credit because I always think about that, especially, all the different places that I've traveled to and stuff. And I think about, it'd be so nice to pack up it. But again, I talk about, I have a big issue. Like I get overwhelmed very easily when it comes to like thinking about the process and making your list and all the things you have to do. So I'm always like, my mom doesn't want me to move anyway, so I'll just stay here in Connecticut. So like the fact that you were just like, all right, I'm packing up, I'm leaving. I have 2 weeks. I'm going to a state I've never been to before. And this is what I'm doing. I mean, not only does it's a real testament to your character, but also to the determination that you had for wanting to do this, not only for yourself, but just to accomplish that goal that you kind of feel, I'm sure you felt that you had missed out on the first time around. Yeah. So what was that experience like, again, just packing up, moving down to Virginia?
Oh, yeah.
How is Virginia comparatively?
Very different.
I could imagine so. Yeah.
So I was the only Yankee in the class. So within the first day, that was my nickname, Yankee. They picked my accent out originally. I still use y'all because it's a really, really great word. And even though I tell my patients not to drink it, sweet tea is delicious. No, it was a little bit of a culture shock.
Sure.
But it was a great experience. I love my alumni, Jefferson College of Health Sciences in Roanoke, Virginia. They took a chance on me. I wasn't exactly your typical candidate. I was the youngest candidate. I was 21 years old when they accepted me. And a lot of the other candidates had years of experience in medicine, but I was able to fall back on my lived experience and say, growing up, I watched my mom go through her cancer battles and her cancer scares. And, ultimately, I needed to find a way to pay for my medication. And at that time, we didn't have any of the protections that we currently have. So I think we were paying $1,100 a month out of pocket, just for bare bones coverage insurance for me.
Yeah.
And didn't include the medication.
And again, this was prior to being finally diagnosed with MALS, correct?
Correct.
So you're paying for medication for a misdiagnosis, essentially.
Yeah.
But you were functioning okay, or were you still,
I was functioning.
Okay.
I mean, yeah. Okay, that's,
as best as you could. Yeah.
I mean, ultimately, I did get my degree. Ultimately, I did make my way through school and make great memories and have long-lasting relationships with people. But there's a lot of sacrifice that we don't talk about in medicine. And people that go into medicine tend to be focused on helping others because they know what it feels like to be hurt. Sure. Or at least the good ones, in my opinion. Right?
Yeah.
And you get into the situation where you start seeking medical care and then you stop taking care of yourself because you're taking care of a patient panel. So I got my degree. My symptoms were stable. At that point, when I graduated, I had been off of the oral immunosuppressants and the steroids, and my liver enzymes miraculously never went back up again, which is pretty unusual for that original diagnosis of autoimmune hepatitis. Oftentimes, you're looking at almost lifelong immunosuppressant therapy or a liver transplant in severe cases. And I got off of the medication and I've been in remission. I'm 38 now. I stopped the medication at about 24, 22.
Okay.
So that in the back of my mind, that was always thinking, I'm like, that doesn't make sense to me.
Right.
So started my practice. I took another giant move to Utah.
Wow.
That's where my husband is from. So this is what makes it interesting. I had gotten waitlisted. I moved back home from Virginia to Connecticut, waiting to hear about the graduate programs. Got called 2 weeks before the PA session was starting, but I had met my husband that summer, and we had only been dating for maybe 8 weeks at that point. And so I get the call saying, "Hey, do you want to go to Virginia?" And he goes, "Well, I think I might go back to Utah to finish my degree." And I said, "All right, well, let's do this long distance thing." So while all that stuff's going on, I had a long distance relationship going at the same time.
Wow.
Yeah.
So then you go out to Utah. And
Mm-hmm.
how long were you out there?
So I was out there for about 5 years or so.
Okay.
My first job right out the bat was doing bone marrow transplant at the Huntsman Institute. And it was kind of a natural progression because my work with the Boehringer Ingelheim was on small cell lung cancer.
Okay.
And so market research, marketing, that sort of thing. I didn't love oncology. I knew going into it I wasn't going to love it. Student loans are killer. Student loans, right?
Yeah.
So I took the position, and I'll be honest, I lasted about 6 months in that position.
Oh.
And it's one of those things where they told me that they were going to offer me a good amount of training. And, the training wasn't quite what it needed to be for a new graduate, right? So if I had been more seasoned, I think it would have been a better fit. But more to the point, many of my patients were dealing with complications that hit very close to home to me. So I had experienced hair loss when I was in high school. I had a very large forehead for that reason. And one of the side effects of my treatment regimen as a child was secondary leukemia or lymphoma later in life.
Oh my gosh.
So there I was taking care of leukemia and lymphoma patients. And that was really the beginning of my burnout as a clinician. And it's crazy to say that only 6 months in, but now that I teach at Yale as an adjunct lecturer, as a guest lecturer, and I focus on clinician wellness, we're seeing burnout in students in first and second year medical school.
Yeah.
This is what we just haven't addressed for decades.
Yeah.
So that was the first experience. And then I transitioned very quickly into primary care in Utah. And I loved that. Did that for many years there.
Well, so let's talk about the differences there, though. So what was it about primary care that you were so drawn to that for some reason you clicked with, you connected with it, that was just so different from oncology?
So for me, it's the stories. At the end of the day, I am always drawn to and motivated by stories. In oncology and in subspecialties, you get the same 5 diagnoses over and over again. You've got your protocols, the patients come and go, and you don't necessarily develop the relationships that you do with primary care. Primary care is supposed to be from cradle to grave sort of deal. You get to know these people, you get to take care of them. And for me, what I say, I have information but no judgment, because people will come and tell you the wildest stories, and it's your job to not only take care of them, but also to make them feel comfortable to come back. And that's kind of a dying art, in my opinion, in medicine.
So again, you're going through, the different programs, these different jobs, but you are still living with this, again, misdiagnosed. And to you, like you said, in the back of your mind, you knew they didn't exactly hit the nail on the head, but okay, this is what's been recommended. The medications for the most part sort of seem like they're doing their jobs. But at certain points, things would happen, and you in the back of your mind, you're like, I know there's more here. So walk me through that. How did you finally get to the bottom of what was going on with your body?
Yeah. So, the joint pain would come and go for years, but more issues abdominal. So nausea, vomiting, diarrhea, to the point where I would get these stomach flus about 2 or 3 times a year where I would be hospitalized.
Ugh.
Like, I'm talking about you're vomiting and there's nothing inside you. You're just retching. I remember one instant, my husband was taking me very rapidly to the hospital, and I passed out on the way there,
That's
and
scary.
you show up in an ER with a syncopal event, and that's a really big bill. So do that 2-3 times a year. Insurance doesn't cover it. It starts to add up a little bit.
Well, and again, we're talking about student loans and everything, and $1,100 a month for medication already.
Yep. So, I felt like that was just my normal, right? I have a weak stomach. I've got IBS. And it's not like I didn't seek medical opinions. You know,
Sure.
I had seen many doctors over the years, and I came away from most of those appointments feeling like, one, they didn't listen to me, and two, they didn't care. And that, I think, is one of the biggest travesties of American medicine right now, is that there's so much apathy.
Yeah.
And it's so hard to connect with the clinicians who do listen. You start to lose hope a little bit.
Now, why do you think that is? So for me personally, and just from my own conversations with people and my own experiences, because I live with a couple chronic conditions now, and going through different surgeries and having different things happen. It seems to me that doctors, especially primary care, they're just overwhelmed. They're inundated with patients. I think a lot has changed in the medical community and also as far as patient advocacy is concerned. Since COVID, since the pandemic, we have all kind of realized how important it is to take care of ourselves and to take that time and get the right diagnosis and really get to the bottom of what we've got going on. And so I think doctors have been just inundated. They have more patients than they have time to care for them, certainly in a compassionate and thoughtful way. So I think unfortunately, they're quick to misdiagnose just to get something on the books, just to, okay, let's try this and see how it goes. Yeah. I think a lot of it is trial and error too, because, as you know, when you are being trained, when you're in the medical field, when you're going to medical school, you're only being trained so much. There's no way that you can learn everything. No. You'll be in school your entire life. So they can only go with what they know and with their own experiences and their own, past patient diagnoses and that kind of thing. But so for you, and what you've been seeing, and again, certainly you know yourself being a patient over the years, how much things have changed. What is it is there anything that doctors can do to change things up? I know insurance is a whole nother deal. Please. But what is it that is there anything that can be done to kind of turn that around, or is it always going to be this way? What are you seeing, and what do you think about that?
I certainly hope not. And I hope that my book is part of this conversation to start foster change, because there are no right answers, right? Like, patients should never feel dismissed, and clinicians should never feel threatened. So what ends up happening currently in medicine is we're stuck in this pretty terrible capitalistic hellscape, honestly.
Yeah.
So when I have a patient come in, I'll give you an example. I had a patient come in. They had an injury, and they were presenting about 2 weeks after the injury, and they wanted an MRI. Well, I would love to order an MRI for you, but unfortunately, insurance will not let me do that. And a lot of times, clinicians have a really hard time explaining to patients what barriers there are in order to access care beyond just that appointment and that conversation. So that's something that I'm actively working with the Yale Physician Assistant Program, is to create kind of like this bedside manner communication course where we can explain. So what I do in my personal practice is I turn that computer right to the patient. So as I'm typing, you're not seeing a computer screen, you're not seeing my back, you're seeing what's actually going into your medical chart, because that's a medical legal document that describes your experiences and justifies the tests, the diagnoses, and then ultimately the treatment. So for this particular individual, we reviewed their ER report. I agreed with them that I probably would have imaged them at that moment, but because there was a delay, we had to order physical therapy first.
Yep.
And we had to refer to a specialist first.
I've been through that myself. Yeah.
6 weeks of PT before we can even think about that soft tissue imaging. I could order for an ultrasound, but an ultrasound's not actually clinically indicated. So it's this really weird pathway that clinicians and patients alike are trying to figure out, how do we navigate and get what we need, but there's barrier after barrier. So I think the more we talk about how insurance and capitalistic middlemen take that away from our patients, the more we're going to have patients unite with providers and say, well, what can we do together, as opposed to fighting with each other? All right. Because ultimately, we just want to take care of our patients.
Yeah. Yeah. I mean, you would hope so. Yeah. I was through exactly that same scenario. It was, nope, before you get an MRI, it's going to be 6 weeks of physical therapy. Let's see if things turn around. And ultimately, of course, it's like, no, it won't. And like, why do we play these games? One of I listen to a syndicated radio program every morning, and one of the hosts on that show had a brain aneurysm and actually had to have brain surgery, I think twice, in fact. And he's a big advocate for, but again, same thing. You can't just go and get a brain scan. You can't just go and get a CT scan, an MRI. You can't just go in and say, I'd like some imaging just to look under the hood, just to, give myself a once over. You can't do it in this country. And so he's a big advocate for it because, he in fact had an aneurysm, and thankfully they caught it before it was, was really bad. But he said the same thing. He said a lot of the time people are walking around with this in their head, and it's a ticking time bomb, and there's nothing you can do until it's too late. So it's really a shame. And I mentioned to, I forget who it was I was talking to, but I mentioned the fact that, and granted, I saw this on TikTok, but it's a thing. You can go to Turkey and you can pay $10,000 to get a full medical workup. You're there the whole day. They treat it like a spa. You get meals, you get a nice robe. They make it very relaxing for you. But MRI, CT scan, X-rays, they do a whole dental, they do a whole optical, they do all kinds of blood work all in a day. Yes, again, it's the hefty price of $10,000, but Lord knows all of that would be way more here. And again, would take years to get approval and go through all that red tape. And why? But, but hey, if anyone has the means, do it. Go to Turkey. It's lovely. Istanbul's beautiful. It's a lovely place. Treat yourself to, you know what I mean? Cause I'm at that point. If I ever hit lotto, I'm going straight to Turkey. Let's do the full workup. Like, let's just know now. And again, I mentioned Robin, 25% of the population has a hole in their heart. And insurance will not even bother to test for it until you have a stroke. What?
Exactly.
What? And
what I was going to say is interesting that you say that, right? Because so for me, ultimately, my diagnosis of MALS, median arcuate ligament syndrome, it's a vascular compression. So if we think about a blood vessel like a garden hose, that's how I always explain it. And our garden hose should be nice and flexible, right? Water goes through, no problem. Well, an aneurysm is when you get a dilation in that garden hose, right? So you get a ballooning of the tissues and it can tear and then you can bleed out. And that's very dangerous, very, very fast. A compression is where you have a kink in that hose and the blood can't get through or that water can't get through. So for me, that early pain in childhood was literally the lack of blood flow to my stomach, part of my liver and part of my intestines. Now, we don't screen for vascular compressions. In my book, I talk a little bit about the research that goes behind this particular disease. And right, we know from 1917 onward, from anatomical studies, that this compression is seen in about 1% to 3% of the population that they looked at. And then nothing was done with it until the 1960s when Dr. Dunbar did a couple of ligament releases. So opened up the belly, cut the ligament that was attached to the spine, compressing that celiac artery, and then there was resolution of pain in his patients. It was an incredibly small study, but it was there. It was there in the clinical literature, and then it got buried for decades. And so anytime somebody would bring up, it was called Dunbar syndrome, that doesn't exist. Oh, there's no treatment for it anyway. There's no treatment protocols for it. So, I mean, it was one of those things where it was hidden so deep in the medical literature, even as a clinician, I had never heard of it. All the clinicians I had worked with had never heard of it. Grey's Anatomy heard of it. And that's how I got my diagnosis.
Wow. Wow. So you're watching an episode of Grey's. They're talking about
not even.
No, okay.
No, not even. So online, I go by the right assistant, which is, kind of a little pun, physician assistant, the right assistant. And at that point, the pain had gotten so bad. I was in a car accident and, airbags deployed. The car was totaled sort of deal. They had to cut me out sort of situation. Sorry, the phone's ringing.
That's okay.
I don't know if you can hear it. Okay.
It's all right.
So I was in a car accident, and I got, a CT scan of the head and the neck because I was transported, and it was cleared. And they said, okay, you're going to have some whiplash. You're going to have some pain, whatever. From that point onward, I could not eat solid food. And for me, it was like, well, this is an exacerbation of the lifelong abdominal pain and weird cramps and stuff that I've had. But this is different.
Right.
I went back to that emergency room 4-5 times in the course of a year and a half. And each time it was for the same thing. It was for low potassium because my electrolytes were depleted. When your potassium gets too low, you can develop an abnormal heart rhythm called QT prolongation, which if you don't replace the electrolytes can then deteriorate into torsades de pointes, which is deadly. So I kept bouncing back and forth, and I kept saying, something else is wrong. Something happened during the car accident. No, you're fine. Here's a referral for a GI doctor, gastroenterology. And gastroenterology did ultrasounds. You're fine. There's nothing wrong. And an abdominal CT scan, you're fine. Nothing's wrong. But then I dropped 100 pounds in less than a year.
Oh, my gosh.
And I was still working full-time in urgent care. And I had a couple of work-related traumas, which I do talk about in the book. Gun violence is real. And I have had 2 separate men threaten my life with guns.
Wow.
One over an antibiotic, one over a CDL exam. This stuff is so real. So I, as a clinician, had reached my breaking point, and I was just ready to give up. And I almost did. And I talk about that in the book. So trigger warning for those that read it. But there is a happy ending because I stuck around and I'm here today. And so I stopped working. I took a sabbatical. I said, you know what? I'm taking a break for myself. I came up with a great cover story as to why I was taking a break. It's like, it's my 10-year anniversary of practicing medicine. I'm going to write a book. Wink. I did. But the whole point was to stop and get my own medical care during that sabbatical. And so I'm continuing to just do my social media stuff just for fun as the right assistant. I was generating a decent income as a copywriter. And then a random person on Facebook messaged me through my copywriting and said, hey, you should really watch Everyday Angel, which is the title of the episode of Grey's Anatomy.
Okay.
I'm like, okay. So I watched the episode. 20 minutes into it, I'm bawling hysterically. And my husband's like, what are you watching? Right. And I'm like, Everyday Angel. And he goes, okay. And so we watched it, and I said, I'm like, this is what I have. And he goes, all right. And in medicine, right? Like in medicine, if a patient comes to us and says, I saw this TV show, right, or Google told me, right, or Dr. Oz told me,
right,
we all kind of hold our breath, roll our eyes a little bit, because there's so much bad information out there. And it is so easy when you're in a place of desperation to consume and then internalize bad information, sometimes to your detriment.
Well, and you're just desperate, right? You're desperate for answers. So anything that sounds remotely close, like, it doesn't check all the boxes, but I definitely have this. Yeah.
Yep.
Yeah.
And I mean, I went through the Western medicine route. I went through the naturopathic route. Vermont's got many wonderful naturopaths up there. But the minute we started looking at a feeding tube, the naturopath was like, I'm out. I don't know what's wrong with you. You should probably see a doctor. Okay, that's really not what you want to hear. Yeah. So watch the episode. I messaged this woman back and I'm like, who are you? Where did you come from? What is this?
Right.
And she was actually the patient that inspired that episode. So she was a lawyer from Chicago. A lot of the Grey's Anatomy episodes are inspired by real patients.
Wow.
Real cases. So in my book, the patient stories are fictionalized and amalgamated to protect patient privacy, sure, right? So their genders are swapped, ages are swapped, regions are swapped, but they're all true stories based on a case. Same thing with Grey's Anatomy. So her case didn't play out exactly as it did on TV, but she ultimately did get the diagnosis of moles, and she sought for surgical repair. And the surgical repair was done in Connecticut. So she traveled from Chicago to Connecticut. And then I realized that I had treatment options literally in my backyard. So moving back to Connecticut helped save my life.
Wow.
I went back to the GI that I was seeing, and I didn't mention Grey's Anatomy. I didn't mention
Sure.
I felt like I was presenting a case to my attending in medical school, and I said, I'd like you to order a mesenteric ultrasound with duplex. And she's like, why? And I said, I'm pretty sure I have a vascular compression of my celiac artery. And she goes, oh, well, that's so rare, and you're so young. Even if that's the case, there's no treatment for it. Okay, I'd still like the test. Please
right.
give me
at least let me know what it is.
You're praying for somebody to listen.
Yeah.
And very grateful she did listen. She did order the test. And I'm on the ultrasound table, right? And I'm 34, 35. It's kind of a blur at this point, the actual dates.
Right.
And I'm sitting there thinking, most women my age are having an ultrasound because they're excited and they're meeting their baby.
Yeah.
And I don't have children. And my husband and I, we decided that was not a journey for us with both of our health issues.
Sure.
And I'm sitting there thinking, this is like supposed to be the happiest time for somebody's life. And I'm sitting here wondering if I'm right. And so I'm watching the ultrasound, and the way that it works is it's a duplex. So they're looking at the blood flow. And this is why you cannot find moles on a regular ultrasound, because if you push down on a vein or an artery, it's going to compress.
Right.
And it's going to act. That's just normal. But if you're doing duplex, which is looking at the color flow of the blood as it goes through the artery, as you press down, you can see that blood flow being cut off.
Okay.
So you take a deep breath in, they push down, and then they take the images. So I'm watching it, and I'm not great at reading ultrasound. To be fair, I'm not a radiologist.
Sure.
But I know when I don't see flow. And I said to the tech, I said, that's moles, isn't it? And she goes, oh, you have to wait for the doctor. Because, of course, the tech can't say anything.
Yeah.
And I just started blabbing my story. And she goes, yes, that is confirmation. Yes. And, she found me crying when I got dressed again. And I said, you don't understand. This has been a lifetime. My mother was gaslit when I was a baby.
Yeah.
We could have diagnosed me as a child. I was a patient. I was a cardiovascular patient as a child. Why did we not look downstream to see if there was other vascular malformations? Yeah. So that's the ultimate diagnosis. Like, that's the ultimate pathway of a random person on the internet gave me an episode. I truly believe that art is magic, and magic saves lives.
Sure.
So finding art, finding some kind of expression is how we share our stories and how we help others not go through what we did.
Yeah. Well, and that's exactly why I wanted you on the show, because when you had announced you finally had this diagnosis, when you had shared on your social media what MALS was and the years that you had gone through. And, again, we're acquaintances. I went through all of school with you. I've known you your whole life, but I had no idea any of this was going on. Same thing with Kyle, who we've had on the show. I had no idea she was going through all of that because, especially on socials, we're not trying to show people at our worst, right? We don't want to let everybody in. We don't need to share every detail of our lives as mundane or tragic as they are. But when you share something that profound, and again, as you said, it's so rare that naturally, why would you have been diagnosed as a child? Because of course that can't be it. It's so rare, and she's so young, and there's no possible way. But clearly this is something that you've had since birth that has just, over the years, as you've gotten older, developed, and it's just gotten worse and worse in severity, even though you had sort of been managing it through that misdiagnosis, through that medication that wasn't necessarily for what you needed. But how many people out there have stories like this that all they need to do, just share it, just put it out into the world, and you don't realize who you're going to reach and who that same thing, that all of a sudden that spark of recognition of, oh my God, that's it. That's what I've been dealing with. So again, that's why I thank you for being on the show. I thank you for sharing your story and continuing to do so with the book. Again, the Secular Prayers of Medicine, available now. But so once you got that diagnosis, then what? Again, they're telling you there's no cure, but what were you able to do? Because again, you're here, you're sitting in front of me. I'm assuming you can eat solid foods now. I mean, what was what was the approach for? So now I have malls. Now what?
Yes. So ultimately, you have two choices as a MALS patient. MALS itself is not going to kill you, right? It's going to be really painful, and it's going to put you at risk for secondary complications like fluid imbalances, electrolyte disturbances. But as a disease or a pathology, it's not going to kill you outright.
Okay.
So you can manage your symptoms if you feel okay with it. Medication like Zofran for the nausea, inhaled isopropyl alcohol for the nausea, Tylenol. A lot of people go down the narcotic route, which I really urge my patients to avoid.
That's fair.
Narcotics will slow gastric emptying. It'll slow intestinal transit. So if you already have delayed gastric emptying and we seek pain management with narcotics, we're actually going to cause rebound pain and worsening spirals. A lot of patients use marijuana, inhale THC. And I'll be honest with you, when I was in Vermont and my primary care suggested it, I said, "Are you nuts?" I was the president of Students Against Destructive Decisions in our high school.
Yep. Yeah. We joke in my household that I'm the only child the DARE program has ever worked on. So I completely understand where you're coming from.
So I looked at my primary and I'm like, "You've got to be kidding me." I'm like, I was an oncologist. I'm like, and this was my stigma. I thought only addicts and only patients dying get marijuana.
Right.
And I mean, for a long time, standard of care, that's what it was in oncology. But the reality is THC is extraordinarily effective for visceral pain. And for patients that cannot swallow or cannot eat anything by mouth, inhalation is an option. So that was a huge part of my journey to help. And it's something that I really struggled with admitting as a clinician. And of course, I wasn't practicing when we started me on that treatment regimen, but at the same time, stigma is real.
Yes.
So you can manage it with medication. That's option one. I don't like medication. I don't like taking a pill I don't like being dependent on substances.
Yeah.
It's a tool in our toolbox, but if we can do other things, that's usually what I like to do first.
That's fair.
The surgery is the other option. Surgery is open abdominal surgery or laparoscopic. When I had my surgery, it was still very much experimental and being developed. It still is. So I saw a surgeon in Connecticut who has now become one of the most world-renowned surgeons. Stanford University just celebrated 900 surgeries.
Wow.
1,000 surgeries actually last month in February. And I was number 641.
Wow.
So I took the consult with the surgeon. He ordered one final test to confirm the diagnosis, which is called a celiac block, which is a special kind of torture, in my opinion, right? So that's the thing we also don't talk about, right? When you have a patient coming to you and we think you might have something, we're going to order tests, but the patient has to go through those tests.
Right.
And some of them are harder than others. And a celiac block was a very difficult test to do because you're awake for it. So what it is you're laying flat. You're on your back or you're on face down, face in there, whatever. So it's like you're getting ready for a massage. Not a massage. So right in the mid-thoracic region, so kind of middle of the back, just underneath the shoulder blades, you get a needle on both sides of your spine. So kind of like an epidural, but we're going around the spine to get to the celiac plexus. Oh, I don't do great with needles. I joke with my patients. The reason I'm a provider is because I prefer this side of the exam table.
Sure. Of course. Yeah.
But the only way out is through. So it was still during COVID, which meant my husband could not come into the hospitals with me. I had to do the entire diagnostic and workup on my own. And that was terrifying. So he dropped me off at the entrance. I go inside, and the anesthesiologist at Stanford University was a true angel. It was the first time that I felt a flicker of hope in the entire diagnostic process, because the way that the test works is they do the 2 injections on either side of the spine with a little bit of like a steroid and an anesthetic. And then they tell you to eat. And I hadn't eaten food in 3 years. And they hand you this menu after they give you these 2 injections, and pain was excruciating and the nausea was excruciating. And I texted my husband and I said, I think I made a mistake. It didn't work. The pain is worse. And so the nurse hands me the menu. Is like, okay, order. I can't eat food. What are you talking about? And so they said, no, we're going to observe you. And they observed you for about 2 hours. And then we had to drive across the state to go to the surgeon's office so he could do a physical exam on me. And I ate for the first time in years. And it was a hospital Caesar salad with Newman's dressing, a couple of grapes, a couple of pieces of pineapple. And the nurses just, they cheered with me and they're like, yeah, you're a candidate. Yeah, you're going to go on to the next step. You did it. And it was amazing. It was amazing. Met with the surgeon. He confirmed the diagnosis on physical exam and said basically the same thing. This isn't going to kill you. Only you can decide if the pain is worth seeking treatment. And at that point, I had failed most medication management. And I said, put me on the wait list. I was quoted 6 months, which was going to be perfect because I had just started a new job at that point. And then that I would have been at the 1 year part for FMLA and short-term disability.
Sure.
I got an email. I got an email shortly after, and they set the date for 6 weeks later.
Oh, wow.
And so I had to tell my employer, I gotta go.
Yeah.
It's like a transplant call. When you get the call,
absolutely,
you go.
Absolutely.
And I went in, and I didn't get out for 22 days. And I talk about that in the book. The complications that I experienced were, I did not think I was going to get out of that hospital. Yeah.
Wow.
Yeah.
So, I mean, I'm sure you felt very defeated laying there in the hospital, waiting for some kind of change to take place. You know, you're sitting there, you're questioning every decision you made up to that point. You know, why did I do this to myself? How, you know, this was supposed to solve all of my problems. You know, we're also a society based on, you know, like instant gratification, right? Mm-hmm. And if it's not exactly the result that I told myself I would have, it was a failure, you know, or it's too much work. Again, we, as a society, I think we get very easily overwhelmed if things don't go our way or the way we think it was going to happen, the way we plan it to happen. But on that 22-day mark, now all of a sudden we're feeling different. We're feeling, you know, what was the...
So for me, of course, that potassium, that QT prolongation had to be a little bit of an issue, the heart issue. So I had the surgery and, you know, the surgeon saved my life. I would do it again, 100%. I will always say that. But there is a cliche in medicine that surgeons do not have the best bedside manner.
Sure.
And that's, you don't go to a surgeon for handholding. You go to a surgeon to do the procedure and to do it right. So what I experienced in the hospital was really the lack of staffing, the issues that we see post-pandemic and during pandemic are terrifying. And if you don't work in medicine, you have no idea how bad it actually is. So I knew going into it, because I was doing urgent care at that point. I was doing 12 to 14-hour outpatient shifts. And I knew what was inpatient. So I brought like a giant bag of chocolate to put at the front of my room. So like every nurse that could come in could get a snack. And like I prepared myself to be a good patient. But when patients have complications, like the IVs kept failing. So I think we had something like 17 IVs in 22 days. We were 5 days away from getting a PICC line placed, something like that. I mean, I was in and out of consciousness. I don't remember a lot of the time in the hospital, to be fair.
Okay.
I do remember falling. I do remember not being assisted. I remember them disconnecting the nurse line button. And I remember the patient advocate saying, we want you to have a great experience, and sending a masseuse to my room, even though it had been 7 days and nobody had bathed me.
Wow.
Like, so the priorities of care were just anything goes. So there I was, split open from basically, you know, just underneath my, not my collarbone, my xiphoid, all the way down to my belly button. And there's, you know, like glue and steri strips, and it's not even stitches, it's glue. And so I'm trying not to cough. I'm trying not to vomit. I'm terrified I'm going to undo the surgeon's good work. And there was one point where my husband was very frustrated.
Sure.
And I know many caregivers can deal with this, can understand this. It was right when I got out of the surgery and my IV had infiltrated. So what that means is when the IV slips and is no longer in the blood vessel and all the drugs are going into your skin and the surrounding tissues. Very painful. And I was on a dilaudid drip. And I had a view of the pharmaceutical company that made it. It was very trippy. So I kept hitting the button, and I thought in my post-anesthesia haze that I was getting stung by bees or hornets.
Yeah.
And I kept saying to my husband, get the hornet off my hand. There's something on my hand. And he's like, oh no, your IV slipped. Buzzed a nurse. She looked at it. Oh, it's fine. Ran out of the room. Buzzed again. I told you it's fine. Nothing's wrong. And I'm like trying to speak, trying to say, but I'm post-op. I'm not wearing my white coat. I'm in no position of power. I'm at the mercy of the staff. She ignored me. I begged for ice. She ignored me, and at one point she came back. And so my husband's like, this is getting ridiculous. And he goes, I want another nurse. And he stood up. And that was a mistake. You're not allowed to stand up. And I said to him, I put my hand out to him and I'm weak. And I'm like, don't do that. You're going to get in trouble.
Yeah.
And he's like, no, I'm not. He goes, I didn't do anything. The next thing we know, there's a patient advocate and security in my room saying your husband threatened staff. And I am like, you're kidding me right now. This is after I survived 2 gunmen. I know what a staff threat is. I know what it's like to lock down my clinic.
Yeah.
No, a family member standing at the bedside demanding, even with a raised voice, demanding another nurse is well within your rights as a patient. And people forget that, right? People, just because we don't have the staffing, that does not mean it's the patient's problem to fix.
Right.
We are ultimately paying for the care that we are getting, or at least they itemize it and say we're paying for it. Right. So that kicked off a pretty difficult series of discussions where we made the decision my husband would come every other day and my mom would come every other day because it was not my mom's first rodeo. And there was one of the nights where he was getting ready to leave. I started to feel what I call a floppy heart. And it's a very weird sensation. It's almost like a butterfly in your chest. But that to me is when I know that QT prolongation is getting pretty bad. And I remember hitting the button and saying, something's wrong. One of the nurses saying, oh, okay, the resident will come. Yeah, you're fine, whatever. And the next thing I know, I was having a seizure-like activity. And my husband, it wasn't a true seizure. It wasn't a true seizure because I was still conscious. And I just remember saying to my husband before I slipped out of it entirely, blood work, check my potassium. And so my husband, they called a crash cart and everything. So we had all these residents run into the room and then I stabilized without intervention is how it's described in the medical chart. And they called off the code. And one of the residents was laughing. He's like, oh, well, that was a rush, on the way out to the next case. And my husband's like, wait, aren't you guys going to do some blood work? And they said, oh, no, she only has orders for blood work in the morning. She has to wait till the morning. That next morning, my potassium was so dangerously low, so dangerously low. And at that point, I made the decision to advocate to be transferred to another hospital.
Great.
I was informed by my surgical team if I transferred that they would terminate care. And I understand. As a clinician, I understand you don't have privileges at another hospital. We are owned by reimbursement and insurances, and we can't maintain a clinical relationship outside of the clinics in which we are. So it's this horrible situation of both patient and provider getting stuck in where I'm not getting the care that I need, but the surgeon did everything that he was supposed to do.
Right.
But the medical care, the medical follow-up was lacking. So I was discharged. Bad idea. Bad idea. They took the IV out of me. And at that point, I was getting dilaudid every 10 minutes. And I had been getting dilaudid every 10 minutes for about 9-10 days, something like that.
Wow.
One of the challenges to be released was tolerating oral medication. And I didn't actually hit that goal before I was discharged, but I advocated to leave.
Yeah.
So that's on me, right? Like I take ownership for that as a person. But in less than 12 hours, I bounced right back to New Milford emergency room. My heart rate was pushing 150 to 200.
Wow.
We couldn't get it to calm down. And I spent 14 hours in an ER bay at New Milford Hospital because my original hospital would not take me back. And then they could not find a bed for me anywhere.
Oh.
So that's the other thing. We do not have the resources. And that's not the fault of the staff that's on the ground. And it's easy for patients to get angry. It's easy for emotions to escalate, but we're all cogs in the same machine.
Yeah.
So I had the intake at New Milford Hospital. The ultrasound tech was so kind there. They had to, of course, re-ultrasound where I had just had surgery because I was vomiting so much. They were afraid that I ripped the internal sutures. And I just massive panic attack, right? Like huge panic attack. And I'm like, no, you can't touch me. No, you can't touch the scar, the opening, the wound. And she's like, well, I have to.
Right.
Like, we have to.
We need to get to the bottom of this. Yeah.
We do. And she goes, but I'm going to sit with you and wait until you're ready. And she asked if she could hold my hand. And she did. And we sat and we breathed for a little bit. And those are the tiny moments of medicine. That's practicing medicine.
Yeah.
That ultrasound tech, that's what it's all about. We got the tests. I have no idea, but I did not cause any internal damage. I split the scar. So I've got a great keloid. Like it's a giant scar on my belly. I love it. I really do. My surgeon hates it. When I went back for my follow-up, he's like, you want to refer all the plastics or something, do some injection therapy? And I'm like, no. It's proof. It is proof after decades that it was not in my head.
Yeah.
Literally in my belly the whole time.
Yeah.
So yeah, the bounce back, the lack of continuity of care, it's systemic.
Well, and are complications like that after the surgery? Is that normal? Was it?
It's not.
Okay.
It's not. So most of the patients are quoted at somewhere between 2 and 5 days inpatient.
Wow.
And most of that is just, right, you hit your goals afterwards. You're walking, you're drinking water, you're taking your meds by mouth, and you're passing a bowel movement.
Yeah.
Like that's how you get out of a hospital after a surgery.
So unfortunately, when I hear something like that, you think, okay, yes, you were not treated properly. You were dismissed regularly by the staff. But I think also, you forget, and we all do this. We can all be good or bad patients, but I think we always have to have in the back of our mind, they're human beings.
Yes.
So I'm sure the staff was really frustrated because it was a situation they hadn't seen before, they hadn't dealt with before. They don't understand why you're not responding the way other people had done after. Again, you said you were 641.
Yeah.
And they're like, hello, 640 were all they're out. They were out in a week. Like what, we don't know what else to do with you and for you. Again, not that that's an excuse, not because you would think, I've talked about this as well. My uncle has been going through an ongoing medical situation. He's in the hospital for a couple of days at a time, like probably every 4 months or so. And it's the same thing. Like I'm thinking from a doctor's perspective, you would think you would want to get to the bottom of it. You would think you would want to learn from your mistakes or from, okay, I've never seen this before, so let's find out what it is. Let's do all that we can possibly do. But again, like you said, between insurance and funding and all the red tape that you guys have to deal with as well, it's, they always get him to a point where he's stabilized. Yeah. So then they send him home. And it's like, okay, so in 3-4 months when this happens again, we're going to go through all the same thing, and there's still no answer. There's still no cure. There's still no resolution. And is this the way you want to live your life? He's 81, and it's like, so this is what going to be the next 5 or so 10 years of my life. Who wants to deal with that? So it's frustrating on both sides, I would imagine. But again, you would think, as a person looking on the outside, like, you got into the medical field for a reason. You've got that curiosity. You would think you'd want to obtain that knowledge and glean, again, get to the bottom of it. So like you said, they've had now 1,000 surgeries since, well, in total. So you would think, okay, the 300 others after, there might be a similar case.
Yeah.
let's learn from this. But again, we're overwhelmed. We're only human. We've got our own shit outside of the job that unfortunately we take with us into the job. Yeah. And they're just looking at you like, lady, could you just get better? Could you just, yes. You know, we did all we can do. It's up to you now, you know, but, and again, and you're laying there coming from a place, same thing of, I don't know why. I don't know. Why am I not responding the way I told myself I would? You know, you had plans of your own of how this was going to turn out. Right. So
absolutely.
So after you said, I think you said it was 22 days.
Yeah.
So you're finally at a point where you're stable enough.
Yep.
And you can start to kind of see the change and feel the change. So again, you know, this was only a couple of years ago. Yeah. How dramatically different has your life become since that?
So what's interesting is that the most surgeons, because there's multiple surgeons now doing this in the U.S., less so internationally though. So most patients are quoted, it takes a year for full recovery, which I 110 agree. It was probably a year and some change before I felt back to normal. I had a significant amount of muscle mass that I lost being bedbound for those 22 days. So I did physical therapy. Huge part of saving my life. I highly recommend anybody that does any kind of surgery, always get PT. Don't skimp on it. But for abdominal surgery, it's really important because they cut all the way down to the spine. They go all the way down. You develop scar tissue. And one of the biggest complications of abdominal surgery is called adhesions, where we develop these kind of like rope-like bands of scar tissue within our peritoneum. And that can cause chronic pain, like a sensation of tightness, bloating issues. So for me, at the end of the day, if I'm not doing my back extension exercise, it feels like a rubber band is pulling me forward. Oh, wow. So it's very weird. And I think that's probably going to be lifelong, honestly. It's just different physical structure. The food came slowly. So for me, my biggest challenge is I literally ate ice cream for like 3 years. So eating fresh fruits and vegetables, that was really hard. So about 4 months after the surgery, 5 months after the surgery, my husband and I got to finally take a camping trip together. And we're big campers, canoers, kayakers.
Nice.
And we like to do a paddle in sort of situation. And so usually that's dry food as much as possible. And I said, nope, we're packing apples. And my husband's like, why are we packing apples? I'm like, because I'm going to eat an apple on the lake. Like, he didn't quite understand it.
Right.
And like, peak moment in my life.
Yeah, it's a big step.
Apple at sunrise. And, you know, again, tears. And it's like, you don't understand what it's like to not have that sensation of chewing and swallowing. That, oh my God, texture.
Yeah.
So it took about a year and some change. Slowly started introducing foods one by one, kind of like a baby, you know, like introduce a new food, give it a week, see how it goes. I still can't eat everything. I still struggle with daily nausea. I still have to reach for the Zofran on occasion, but I'm not vomiting 20 times a day anymore. My last ER trip was in July. I only had one last year. Yay. You know, like that's a huge improvement for me. Yeah. And again, it was potassium issues. But I would 100% do the surgery again, even knowing everything that I know now.
Sure.
I don't think I would necessarily change anything because I know that the staff that took care of me were also victims of their circumstances. So one of the things that I talk about in my book is when I got to that place of deep, deep depression where I was ready to check out. And the way that I was going to do it was very intentional. I put a lot of thought into it. It was not a fleeting moment. And that's the scariest thing of all is I wanted to be a cautionary tale. I wanted my coworkers to find me and to know that I was burnt out and it's because nobody was listening. I realized overdoses were not going to happen when your stomach can't actually handle food or pill. Yeah. So wasn't really thinking straight there. But at the end of the day, I'm still a cautionary tale, but we've got a little bit more of a happy ending. We've got a continuation instead of a period.
Yeah. Yeah. So again, this is something that you are going to live with to the rest of your life. You've had this surgery, which obviously, again, has vastly improved the quality and changed the way you function and you move about the world. But it's still something you're going to have to deal with forever. And so what motivated, again, you said you want to be a cautionary tale. Was that your motivation behind writing the book? Because again, it's deeply personal. It's deeply emotional. It's put a toll on your mental health, all this time. Anybody else would say, I just want to get that chapter behind me. I want to move on. Now I've got this, I can eat apples by the lake. That's what matters. But you said, you took it one step further and you said, no, I know somebody else. Maybe it's not malls, but people out there are being misdiagnosed every day. People out there are being ignored and they deal with medical trauma all the time. And there is hope out there. So you've written this book, The Secular Prayers of Medicine. And what is it? I mean, every time I see a post of yours or even just now in this conversation, I'm thinking to myself, this girl's going to give a TED Talk one of these days. Like that's all that's all I'm thinking is she's going to be giving a TED Talk and I can't wait for it to happen because because the way you tell your story is so thoughtful and again, because you've seen it from both sides, because you are in the medical field, you've been a patient, you've been a bad patient, as you said, but you have a very good understanding of both sides, like you said, of the table, which most of us do not have that luxury and that knowledge and experience. So I just think it's wonderful. And again, another reason I wanted you on the show, because the book is so important. And I said this to Catherine and Maria. I said, you guys need to be, do they give talks like this where you bring in patients and you hear their experiences, and because sometimes they're not all great, but I think it's important to have that understanding of the people that you're dealing with, the people that you're seeing that are walking through your doors, that you're here to help. So that here's hoping that this book opens those doors and can open up that dialogue between patient and physician. And I'm looking forward to more from you. And is there another book in you? I mean, you do write. Like you said, you're a copywriter. You've got this experience. Do you want to continue to write about your own stories? Are you going to start maybe some fiction? What is on the horizon now?
So currently, The Secular Prayers of Medicine, Stories from the Front Lines was picked up by Hypatia Press. So they have global rights to it.
Great.
Which is wonderful. So depending on how well the sales do, then we're going to think about advancing into an audiobook.
Awesome.
I do have 2 other books in the planning that I have not committed to my current publisher because I'm hoping for a slightly wider audience.
That's fair.
But the way that I look at it is I have many interesting stories about patient care. But bigger than that, they talk about actual concepts and controversies in medicine. So if you look at The Secular Prayers of Medicine, Stories from the Front Lines, is book number 1 in a trilogy. That's kind of my origin story.
Great.
Book number 2 is Urgent Care Confessional. Urgent Care Confessional details what happened during the COVID-19 pandemic from the perspective of an outpatient urgent care provider.
Excellent.
My God, the stories in that book. I'm holding out for a big publisher on that one. And then book 3, which is what I'm currently writing, is called To Make Care Primary. And that is a selection of my primary care stories. And that's really kind of underscoring how I'm teaching my students now. How do we implement that good bedside manner? How do we tell somebody that they have cancer? And it's the first time you're telling a patient that as a clinician. Yeah. How do you project confidence and not scare somebody? Right. Because the way that we give information is an art, and that's something that needs to be taught. So those are the 2 books that are currently in production. They are pretty much completely written, but just doing final formatting and concepts.
Amazing.
So once we get through this one, we'll see what happens next.
Well, that's excellent. And please, I'd love to have you back to talk about both of those as well. My cousin Jake was working at the Javits Center in New York City when COVID was going on, when they turned it into essentially a triage hospital. So he Lord knows scheduling is as you know. So he will be coming on to talk about his experience with that, with working there when that was going on. So I think people, again, that sense of overwhelming, we don't know what to do. We're just that desperation. We're so quick to try and, put COVID in the back of our mind that, that it's over. It's never, gang, like if it's not, but even then, if it's not COVID, it's something else. Like we're always going to experience things that are unexpected. We're gonna have these, between our family, our friends, we're always going to hear these stories, these of trauma and of drama and, and it's, again, that's why, I wanted you here because it's so, and as we were talking with Satori last week, it's so important to share our stories because even if you're not going through exactly what I'm going through, you'll find something in my story that you can relate to and that you can use and that you can take with you while you're dealing with it. I've also shared when I had my bariatric surgery, again, one of the DJs on my radio program experienced a really traumatic, she had something going on where she was hospitalized. She was near death. All of her organs had started shutting down. And it was right at the exact same time that I had my surgery. And 3 months later, my hair's falling out. And I had never experienced major surgery before. I had never given birth. I'm thinking, oh my God, and she had started talking about it on the show saying, my hair is falling out. I've decided to cut my hair in a dramatic fashion to kind of counteract what's happening. So it's not as noticeable. And I said, fuck. Yeah. Okay. That's what this is. Yeah. I went through a major surgery. My body is adjusting, is trying to figure things out, is recalibrating essentially. But again, had she not shared that, I would have freaked out a hell of a lot more. I would have, because, and these aren't the things that they tell you, right? When you go in, they say, okay, expect X, Y, and Z, but they don't know how everybody's going to react to everything ultimately. So they're not going to give you a list of, here, enjoy this anxiety for the next 3 months, right? And check off as they come, check off what you have, it's so they're, as the experts, as much as you guys are the experts, you also are not in a position where you're just going to sit down and go through, it's like the end of a pharmaceutical commercial. Side effects. Yes. You're not going to do that. You're going to say, these are the top 5 that we're pretty sure you're going to experience. And this is how you deal with it. Everything else, you got to just kind of take it as it comes. So again, when we have the courage, when we have the understanding, the grace, the empathy, the compassion of recognizing that while, yes, this is a very personal experience, this is something that I went through, this is the trauma that I now have to move on from, deal with, accept, whatever, there is somebody out there that's going to connect to that story and that circumstance. And there's somebody out there that's going to learn from it, or at the very least recognize, oh, okay, they did this happened, they got through it, this is what they did. And, that's all anyone can hope. We all want hope. Ultimately, that's what we need is we need to know that there is a light at the end of the tunnel, that we will get through it. So Kateland Kelly, thank you so much for being on the show. You guys, again, the Secular Prayers of Medicine, Stories from the Frontlines, literally just dropped within the past couple of days, just dropped. Thank you for taking the time out. I know you're on a book tour now. You're going to be giving talks. Again, I'm looking forward to your TED Talk. I know it's coming. We must promote it. We must get you out there because again, I think it's so important. It's so important to share these stories. So thank you again so much for being on the show. I look forward to having you on the show in future with your other books. And hopefully this has helped someone out there. So
I hope so too. Yeah. And I mean, if I could leave everybody with just the one resounding fact from my book is, 2 things. Hope is alive for as long as you are. And when hypotheticals happen, we always deserve dignity.
Excellent.
My soapbox.
Again, Kateland Kelly, The Secular Prayers of Medicine. Gang, get out there. Get that book. Get it. This was Try Not to Curse, and we will catch you next time.